Hello everyone, welcome back to the channel. My name is Misio and today we'll be discussing hernias. So in this discussion, we will define what the hernia is. We'll see a few causes of hernia, the types, clinical features, how you examine, and finally, how you manage. So on the word round, you will find patients with hernias and they require you to have certain information or knowledge about these hernias. So, firstly, they want you to know what hernia is. And basic definition of hernia is a condition in which organs, abdominal organs most of the time, bulge through a wall or opening or weakness in the abdominal wall surrounding it. So that's a basic definition. For example, these pictures here show the patient with the hernia. So we move on to causes or risk factors of hernias. So let's discuss a bit on how these hernias come about. So we have already defined that these are just protrusion of internal organs, especially abdominal organs, through an opening or weakness. Now, what causes this protrusion? We know there's a weakness or there's an opening. But when there's increased abdominal pressure, that's what pushes these organs through these weaknesses or openings. So the basic cause of these hernias is increase in abdominal pressure. So think about anything that causes pressure in the abdomen to cause these organs to push or bulge through these weaknesses or opening in the abdomen. So one of them is that one is straining or lifting of heavy weights. So as people are lifting heavy weights, they increase the abdominal pressure. Chronic cough. So you'd find these hernias in patients of tuberculosis. Then you wonder what is a internal medicine patient doing in the surgical department. So it may be because of this hernia due to chronic cough. So, as the person is coughing, they exert pressure on the abdomen. So, chronic cough can cause these hernias. Chronic constipation. Now, as you are trying to open your bowels and you're constipated, you increase pressure to push the fecal matter out. So this in turn pushes the internal organs through these weaknesses or openings. Then there's also some other urinary causes. A good example is the BPH. So another cause would be coming from the urinary system, especially in old men and youths. So in old men, the main cause would be BPH. So this benign prostate hyperplasia blocks the urethra, meaning these people won't be able to pass urine easily. So because of this retention in urine, you tend to force the urine out. And because of this forcing, they increase the pressure in the abdomen, which may cause a hernia. And the other one, in youths, it's strictures. So this is basically narrowing of the urethra again. Causes would be maybe injury, infection. So it causes narrowing of that urethra. So as they're trying to pee, they need to exert more force to urinate. As a result, I increase in abdominal pressure, which would later cause a hernia. And then another one is obesity, pregnancy. always increases abdominal pressure. Another cause would be surgery. For example, someone had an appendectomy. So because they have opened the abdomen, there's weakness there. Yes, they have sutured and the wound has healed, but because of that cut, it creates a weakness there. Or maybe they had done abdominal surgery where they had opened the abdomen to fix or remove something. Because of that opening causes a weakness, and because of the increase in abdominal pressure, the organs start bulging through that weakness. Another cause would be smoking. Smoking interferes with the collagen formation and also family history. So these are the causes of hernias. So as you are interviewing patients or treating patients, you'll be looking out for these causes in these patients. So a patient comes and tells you they have a bulging in the abdomen or around their pelvis. Then they tell you that they lift weights. One of the differentials would be hernia, which we're discussing today. They tell you they have chronic cough and they have a bulging in the abdomen or the pelvic area. This would be one of the differentials. Okay. So this bulging or this hernia, as you can see in the picture, it has got parts. So it has a covering, it has the sac, and it has also contents. So the covering is just the layer of the abdominal wall through which this sac passes. So it's just basically the abdominal wall. This is what the covering is. Then the sac is the ventriculum of the peritoneum. So it forms a mouth, then a neck, then a fundus. Then inside the fundus, here you find the contents. So these contents can be intestines, can be urinary bladder, can be ovaries, ovarian or fallopian tubes. Classifications. So classification is one of the things that doctors like asking students on ward rounds. How do you classify these hernias? So the first one, you can classify them clinically. You can classify them according to its etiology, the content in the sac, and also according to its anatomical location. Where is it located? Those are ways of classifying these hernias. So, under clinical classification, we have a reducible hernia. So this is simply hernia that you can push back. So that bulging, you can push back, and then you won't be able to see that bulging. This can be done by the doctor or the patient, or when the patient lies flat, the hernia is able to be reduced or pass through back through the opening or the weakening. Then the second one is the one which is irreducible. So this one, whether the person is lying flat, whether the patient, him or herself, tries to push it back, it's not going back. So another one is an obstructed hernia. So an obstructed hernia simply means the content of that hernia, whatever passes through there, is not able to pass through those contents through that hernia. For example, I say the content of that hernia, intestine. So things in that intestine aren't able to pass through, so it is obstructed. So that's an obstructed hernia. But this obstructed hernia, blood supply to that intestine is still available. So it's still blood supply. But with time, the supply can be cut off. Another one is an inflamed hernia. So this simply means you have hernia where inflammation has started. So there's a fighting between the immune system and other bacteria or some infection in that sac. So strangulated hernia is a hernia which cannot be reduced and the blood supply has been cut off. And it's very painful. Yeah, it's tender. When you touch it, the patient feels pain. So this is a hernia whose blood supply has been cut off. So the content in that hernia cannot receive whose blood supply. So that neck has been reduced so much that the blood supply to that part of the intestine in the hernia cannot receive the blood. We move on to classification according to etiology. So these are just two. It can be congenital, it can be acquired. So congenital patients usually have the weakness in those areas where these hernias develop. And with time, they have that bulging or protrusion of intestines. And then acquired, there's no weakness or defect in the abdominal wall, but because of those causes that we mentioned, that cause increased abdominal pressure, with time, they develop the hernia. Then we can also classify it according to the contents in that hernia. So if the contents are intestines, it's called enterocele, it can be urinary bladder, it can be omentum. Yeah, so the list, I've listed everything there. It can be a sliding hernia. Another classification is the anatomical classification. As you can see on the diagram there, where we've got some rhomboidal hernia, incision hernia. So this is where someone had an operation, surgical operation, and then that site becomes weak, and then the hernia protrudes from there. Then I've got a femoral hernia, I've got epigastric hernia, I've got umbilical hernia. So umbilical hernia, I'm sure you've seen this one in kids. I'll show you some pictures. Obturator, lumbar, gluteal hernia. So this is just a list where they are found. Okay, let's look at some of these hernias. Yeah, classified by the location on the body. So this anatomical classification, let's pick a few and have a look at them and see some pictures so that you can be able to identify them on the ward. Let's say a patient with inguinal hernia, how does it look like? Yeah. So we start with an inguinal hernia. So what is an inguinal hernia? This is the most common type of hernia, especially in men. So the intestines push through a weakness or a tear in the lower abdomen. There are two types. There's a direct and there's an indirect inguinal hernia. So the direct inguinal hernia, it passes through a weak point in the fascia of the abdominal wall and the Hansen-Beck triangle. Then the indirect inguinal hernia, the protrusion passes through the deep inguinal ring, follows the spermatic cord band through the superficial inguinal ring. So this is the difference between the direct and the indirect inguinal hernia. And then, so hiatal hernia, this is where the stomach or part of the stomach protrudes through the diaphragm into the thorax or into the chest. So there are basically three types. the sliding hiatal hernia. So this one, the distal part of the esophagus and part of the stomach, the cardia, will protrude through the thorax. So they'll be sliding up and down. And then in the lowering hiatal hernia, the distal part of the esophagus does not slide up, is intact, but part of the stomach, the one that protrudes out into the thorax. And then a mixed, both the distal part of the esophagus and part of the stomach protrudes into the chest or the thorax. And then we also have another one, the femoral hernia, where the intestines protrude through the femoral canal. And this one is common in women because of their wide pelvis and due to increased abdominal pressure during pregnancy or in obese patients. Then we also have an umbilical hernia, as you can see. So this is due to a protrusion through the belly button. So these ones are usually common in kids. You see them in kids where they have a bulging on their umbilicus. And then the other one is an incisional hernia. This one is due to weakening of the abdominal after surgery. So because of this weakening that happens, maybe due to infection, poor nutrition or obesity, the abdominal content protrudes and bulges through that incision. Okay, let's look at a few clinical features. So most of these features will be picked when you are interviewing the patient or when you are examining the patient. So some of them, like one, it's common in males. The patient will have a swelling of the groin. There's pain that's referring to the testes, especially when doing exercises or strenuous activities. Then the patient will tell you that this swelling is painless. Then they'll tell you it's prominent when they cough or when they lean forward. Then they tell you that sometimes patients will say that's painful, some will say it's painless. Then some will say that some patients will say this swelling is not reducible, or it's reducible. So you see some of these things as you examine the patient. You try to push it in by yourself. Yeah. And then some patients will tell you that they have constipation, they're not able to open their bowels. Some patients will tell you that the swelling is tender. When you touch it, it's painful. Then some patients will tell you that they've got history of BPH. They tell you they usually have problems urinating. They need to force the urine. So all these are things that you can pick as you are interviewing these patients to come up with this diagnosis of a hernia. Together with the causes and the examination, this will give you a good picture of a hernia. And then, of course, some people are going to have some signs and symptoms. Some, as usual, they'll just tell you it's not painful, no symptoms, nothing, just a swelling. Don't have any complaints apart from having that swelling. Some tell you swelling is painful, it's giving me nausea, some are vomiting, some they'll say I've been having constipation for some time now because of this obstruction in this hernia. Okay, so now we move on to examination. Since now you have interviewed this patient on the ward or in clinic, you have an idea that this probably is a hernia. So now you need to confirm by physically seeing the swelling and examine the swelling. So as you're examining the swelling, you need to remember never to forget to examine the opposite side. So the patient tells you the swelling is on the right side of the abdomen, or you say examine the left. Then never forget to do a digital rectal examination. So what you're looking for in this digital rectal examination, you're looking for the prostate. So if the prostate is enlarged, could be it's blocking the urine. So as the patient is voiding, has to push to increase the volume to push the urine through, like narrowing in the urethra. Then also you need to examine the urethra, and then you also need to check for the abdominal tone. So we start the examination. So make sure you examine these patients while standing and while lying supine in bed. So as you examine these patients, as usual, get consent to secure privacy, and then you start inspecting. So you, on both lying on bed and standing, you check the site, where is it located? Is it an inguinal hernia? Is it a femoral hernia? You check, is it an epigastric hernia? So you can go to site. You need also to check for the shape and the size. You also need to inspect for skin of that hernia. So as you are inspecting here, you may see movements. So this may just indicate peristalsis, a movement of contents in the intestine. And now you move on to palpating this hernia. So you need to elicit tenderness. The patient may say it's not painful, but when you touch it, is it paining? Then you also need to confirm the site. So the patient may have a big hernia going as far as the thighs. So you may think that the hernia is just in the thigh, but initially it's an inguinal hernia. It's just that it's so massive that it's occupying all the space together with the testicles. So you now confirm using your hands. Again, if you confirm the size with your hands and the shape, then the surface, is smooth or rough, then the consistency, is it soft or hard? So maybe it can be, and then you also have to try to reduce it. And in both cases, you're inspecting your eyes, and as you're palpating, you need to ask the patient to cough so that you can see that cough impulse. Because remember, cough increases abdominal pressure. So when the patient coughs, you see no show a cough impulse. Then you also want to percuss this bulging just to confirm whether the contents inside are solid, liquid, or gas. Then you also want to auscultate to hear for bowel sounds or movement. Then in kids, especially infants, you would want to do a transillumination test. So you get a pen torch in dark room, then you connect, then you shine a bright light to see if it passes through. It shows you whether it's an hydrocele or just whether it's just containing fluid or it contains some organs inside, especially in infants. In adult, yeah, it's not necessary. Okay, so there are some special tests that you can do for these hernias that help you differentiate between a direct and an indirect hernia. So the first one is an internal ring occlusion test. So a patient will be lying supine in bed, then you reduce the hernia, occlude the internal ring, which is midway between the anterior superior iliac spine and the synthesis pubis, 1.5 centimeters above the inguinal ligament. And then you ask the patient to cough. If no swelling comes out, it is an indirect inguinal hernia. As an indirect inguinal hernia comes out through the internal inguinal ring, passing through the inguinal canal and comes out through the external ring into the scrotum. If the swelling comes out, it is a direct inguinal hernia. A direct inguinal hernia comes out through the opposite wall of the inguinal canal, comes out through the Ensign bed triangle. So as you can see, these pictures are just illustrating. Once you occlude the internal ring, you ask the patient to cough. Remember, cough increases the abdominal pressure. Then you see whether this bulging stool comes out. After you have reduced it and occluded the internal ring. The next one is the finger investigation test. This one, the same thing, the patient will lie flat, supine, then you reduce the hernia, and then raise a fold of the scrotal skin over the index finger, enter the external ring, attach to the pubic tubercle. Normally, it admits the tip of the little finger. Enter, and then you enter the inguinal canal laterally and ask the patient to cough. If the impulse touches the tip of the finger, it is an indirect inguinal ring. If the impulse touches the side of the finger, it is a direct inguinal hernia. Next, you want to do investigation for this patient. So, some of these investigations are just so we want to do some investigations for this patient. Of course, you do a full blood count and different ways so that you scan for anemia and some infection. This is a reason why you want to do a full blood count. Then you do some imaging. So under imaging, you want to do a plain X-ray. If your patient tells you they are coughing, you'd want to do a chest X-ray. See, maybe I've got some pulmonary problems or condition. It is causing them to be coughing and it's increasing the abdominal pressure. Then you just want to do ultrasound, the abdomen, the pelvis, and the bulge. Then you just want to do a CT scan, the MRI. And then you just want to do a abdominal X-ray also. So this can actually if there is some obstruction. So basically those are the tests that the investigations that you would do for this patient. After done these investigations, and then the consultants will ask you about the differentials. If this is not a hernia, what can it be? So it can just be an hydrocele, can be lymphoma, can be a growing abscess, or it can be a tumor that is growing, or it can be varicocele. So the complications of Allen's hernia can become irreducible. So when you push it in, it's not going back. Or it can become obstructed. Well, we do mention what this obstruction is. It can become strangulated, or it can develop hydrocele. So it's just a collection of water in the hernia. Or it can have a spontaneous rupture of the hernia sac. And then this could also cause an infection. So a patient will eventually have sepsis, which is also another complication. So management of these hernias. Since now I've gotten the history of examining this patient, it will determine whether it's an inguinal hernia, whether direct or indirect, whether it's a femoral, which is an umbilical hernia or incision hernia. So now, how do you manage it? So managing, you can manage it conservatively, medical, or surgical. By surgical is a definitive management of these hernias. So conservative, so you have patients that let's say the patient is an old patient who's anemic. So this patient has anemia. So and doesn't receive blood donations or blood transfusion, and they have this hernia. So you can take them to theater. So you'd want to wait for the anemia to resolve. So you can give them you can put a truss. So this is just like a band that pushes the hernia inside, so that it no longer bulges. So this is just like a wrap around the patient to cover it. So this does not cure, just pushes back the intestine into position. Once you remove it, it will go back. Then you can tell these patients that are not fit for surgery. So in short, this truth you do the patients that are not fit for surgery. Whether the patient has refused, or the patient is too old, or they have other complications, so you can put them on this. But this one doesn't work for irreducible hernias, because you need to reduce it first, then that's when you can cover it. I'll show you a picture. And then you just want to tell the patient to reduce on their strenuous activities, anything that increases abdominal pressure. If the patient is a smoker, you just want to tell them to stop smoking. The patient goes to the gym, you don't want them to stop going to the gym until the hernia has resolved. So you can also give patients antibiotics. You put them on good spread-term antibiotics, especially if they have fever, their hernia is tender, so you are suspecting that the hernia is strangulated or is inflamed. So you can put them on antibiotics. Then for patients that have hiatal hernia, you'd want to put them on protein pump inhibitors and H2 receptor blockers, just to reduce the production of the acid in the stomach as you wait for the definitive management, which is surgery. Then now you proceed to surgery, prepare the patient for surgery. So in surgery, you'll do, depending on the age of the patient or children, they can do a neoectomy, and for adults, they can do a neoplasty. So basically, that's it about hernias. So a takeaway from this is, one, you need to know the definition of the hernia. You need to know what causes the hernia. You need to know the types of hernias. You need to know how to differentiate direct and indirect inguinal hernia. And you need to know how to do those special tests for these hernias, because this is what's going to differentiate between the direct and the indirect. inguinal hernia, because you remember inguinal hernias are the most common ones. Then you also need to know the investigations you can do for this patient and why you're doing them. So on a ward, the doctors like this system where they just say, okay, you tell us what investigation you do, because you just have to do full blood count. So they say, oh, full blood count, great. Why? So explain why you want to do. You're looking for infections and their name. Remember, at one point you need to take this patient for surgery. And before surgery, you need to do a full blood count. You also need to do a cross match. So you give the reasons why you're doing those tests. Why you doing X-ray? What kind of X-ray? See, okay, chest X-ray, because I want to check for any pulmonary infections that may cause this patient to have chronic cough. Abdominal X-ray, why do I check it for abdominal X-ray? But I want to check for interstitial obstruction. And then say CT, you give reasons for what you're doing. Then from there, you proceed to the management. Conservative, what does it mean? Basically not fixing the problem in conservative, just making it better such it doesn't become worse. Then medical, why are you giving APP in someone with a hernia? Because you just want to ensure that this acid in the stomach does not reflux through the esophagus and cause other problem before you actually fix the underlying hernia. In surgery,